Thank you, Dr. Karam. We appreciate your time. And we'll have and just to remind everyone, because we're streaming this live, we're going to go through all of our presentations and have Q&A at the end with a full panel. So be sure to write down and jot down your questions and bring them back for all of our presenters. We're going to have more discussion about therapeutic developments for ALS, but there is also a very important aspect of the disease, which is about living with ALS. And we're thrilled today to have someone who is very experienced in understanding of exercise and in ALS. Dr. Erik Ensrud is the Associate Professor of Orthopaedics and Rehabilitation at the School of Medicine at Oregon Health Sciences University, right here. He has a medical degree from University of Minnesota and did his residency at the Spaulding Rehabilitation Hospital at Harvard Medical School in Boston. He did fellowships in neuromuscular medicine and EMG fellowship at Brigham and Women's Hospital. He has a unique intersection between rehabilitation medicine and neurology, which is pretty rare. So we're thrilled to have Dr. Erik Ensrud join us. Welcome.
Thanks. Thanks for having me, Lance and Kathy and everyone, and thanks for asking me, Shafiq. I've known Shafiq for quite a while. And so this is something that comes up frequently with patients with questions about exercise. Is exercise bad? Is exercise good? And then I'll try and touch on an important aspect of musculoskeletal pain in the latter part of the talk. And I've actually put some handouts on your tables, so they've already been passed out about the most important part of musculoskeletal pain in ALS, which is the shoulder. I'm going to Lance, if I'm going too long, wave your hands, because I've tried to cut these slides down, and then I'll try and get done in time here. So in exercise and ALS, we really have a basic question, and does exercise training, does it improve muscle strength, all these positive aspects, improve cardiorespiratory function, prevent disuse atrophy, and very importantly, improve overall quality of life or sense of well-being, or does exercise accelerate muscle breakdown, disease progression, and weakness in terms of an overuse syndrome? Or does it do both? And so one problem, whenever you talk about exercise and you're talking about exercise in someone with a medical condition, the word exercise, certainly in the United States, we tend to think of, this kind of meathead guy here lifting in the... This is a Planet Fitness commercial. If you haven't seen it, it's very funny because the guy says nothing but, I lift things up and put them down. And then you can see this Iron Woman athlete here who's obviously, exercising to a very intense level. But that really shortchanges exercise for most of us and really shortchanges the benefits. Really, exercise can be very helpful in a much lower intensity, like pool exercise or chair exercise. So we really need to broaden what we think of. Exercise isn't just about Jane Fonda or that P90X guy. So one thing to just make sure that we cover here today is the type of muscle contraction done with exercise. And these are terms that are used in describing the contraction of the muscle. This is the bicep here. And concentric contractions are where the muscle contracts and the muscle shortens. So he's pulling up on the dumbbell here, or she is, and the muscle gets shorter. But eccentric contractions are where the dumbbell's already up here, and the muscle is used to slow the rate of descent of that. So the muscle contracts while lengthening. And this is really important. I wanted to make sure I touched on it because eccentric contraction really causes injury to muscle. You can get delayed onset muscle soreness, and it elevates the CK, or creatine kinase, the muscle enzyme, which elevates with muscle damage. It causes a lot of strain on individual muscle fibers that can damage them. And the reason that it tends to be used a lot by people who exercise is that it can be very effective in normal muscle that has normal nerve supply. So you'll hear people say things like negatives or slow motion exercises. Let the weight slowly down. So there are quite a few benefits in exercise in patients who have neuromuscular disease, including ALS, and a significant one is the changes in what we call VO2 max, and that's the maximum rate of oxygen consumption, which equals fitness, and that can increase by quite a bit with exercise. And there are lots of physiologic reasons in your heart and circulatory system for that. There are also changes in the muscle itself with exercise. You get different levels of enzymes in the muscle. The mitochondria, which generate energy in the muscle, increase in size and number. And then really importantly, the blood supply to the muscle increases through capillaries, which increases blood flow to the muscle. And as a result of that, your skeletal muscle gets an increased ability to utilize oxygen. And there are lots of other important adaptations to exercise. And it increases endogenous opioid peptides, which helps with our sense of well-being. It can reduce pain. It's really important in terms of reducing depression, improving sleep quality, and in this case, particularly important with reducing contractures. And so, but when we talk about exercise and ALS specifically, there are definitely some clinical concerns. And one is overuse weakness. We've already got, the muscle is being affected by the decreased nerve supply from the disease which affects motor nerve cells. Is exercise a risk for ALS? I'm not going to solve that question today, but we'll talk a little bit about it, some of the evidence for that. And so, this came up with ALS really being more widely recognized with this famous athlete, Lou Gehrig, and Lou Gehrig's disease. There are lots of other famous athletes who have developed ALS. So some epidemiological evidence or, statistical evidence suggests that vigorous physical activity in terms of heavy labor or competitive athletics may be a risk factor for ALS. There are quite a few papers on that. You can also find evidence when it's looked at systemically that there's no really conclusive evidence for physical activity as a risk factor for ALS. So what the evidence that it does occur, where there's definitely been some increased risk of developing ALS that's been reported among professional athletes, and we've all heard about the NFL, and many of us have heard about soccer. And people with ALS are more likely than people who don't have ALS to have participated in collegiate sports and have a thin body type. But we also have evidence to the contrary that physical activity is not associated, and again, a systemic review against that. So it's kind of mixed, but it kind of makes sense that very intense physical activity, you stress the motor nerve cells, which are these very long cells going out to the muscle, could be a risk factor. Here's a more recent one. This is interesting. This is from Brigham and Women's Hospital. And just a huge study. They enrolled over 160,000 women. And they adjusted the odds ratio for ALS for people who did strenuous activity 3 or more days a week, compared with no reported strenuous physical activity. And there was about a 56% increased risk of ALS in the women in this study who did very strenuous physical activity 3 days or more per week. So this was the first study, certainly of this size, to report an increased risk for ALS mortality that was associated with strenuous physical activity in postmenopausal women. And but they wanted to make sure they pointed out that this risk of ALS was much smaller than the overall benefit of strenuous physical activity for other serious conditions, including total mortality and heart disease and breast cancer. So the thing that we have here, these two cells, the white cell and the yellow cell, that are involved in ALS. The white cells are the upper motor neurons that go from the cortex down to the spinal cord, where they synapse or make a connection with these yellow cells, which are the anterior horn cells that go out to the muscle. These are very long cells, and they, because of that, have a lot of stress. Everything that's produced here has to be transported all the way down here. Everything that's produced in the nucleus or production center of the cell in the spinal cord has to be transported all the way out to the muscle. There's no connections in those cells. So we can find some evidence in animal models And this was an important paper looking at exercise as an animal model of ALS. And these were mice who have the SOD1 gene, that first gene that was discovered in 1990 that Dr. Crum reported. This was 90 mice in each of 3 groups, mice that were sedentary, mice that were given moderate exercise, 30 minutes a day, 5 days a week, and mice that were given high exercise, 60 minutes per day, 5 days a week. And this device here, you can see the mice here. This is called a rotorod, and it's a way that you can assess physical activity in mice. The mice are put on the rod, and they don't want to fall down, so they'll keep running on the rod as it turns. And nothing bad happens to the mice when they fall down. I just wanted to make sure. I mean, there are lots of studies that bad things happen to mice, but not this one. Until the end of the study. So they measured the time that the mice are able to stay on this rotorod, and then the mice were sacrificed, and they looked at how many motor neurons do they have in the spinal cord. And this result was really interesting. So the mice in the moderate exercise group had significantly more motor neurons and more time on the rod than the sedentary or non-exercising mice or the high exercise group. The worst scores were in the mice that didn't do exercise. So this raises the idea, is there an evidence of a sweet spot in exercise where you don't exercise too much, but you are doing some exercise? And you can see here with the results here, this is the type of mouse, sedentary, moderate, or high intensity, and how dense are these motor neurons. So this is what they are in a wild-type mouse, 2.22, if they don't have the SOD1 gene mutation. If they're sedentary, it drops by more than half to 1.02. With moderate exercise, it's considerably better, 1.67. And then with high-intensity exercise, it's 1.43. So again, this evidence of a sweet spot for exercise. So let's look at some clinical trials, not in mice, but in real human beings who have ALS. This is a study from 2001 with 25 ALS patients, and they were randomized to an individual exercise program, 30 minutes a day, and they were assessed at 3, 6, 9, and 12 months. And the patients in the exercise group scored better on the ALS functional rating scale, and the Ashworth scale is a scale of spasticity at 3 months compared to the controls, and a similar trend was seen at 6 months. Here's a second trial that's more recent from 2016. 60 ALS patients and 30 were randomized to one of 3 exercise groups. And in this trial, in each group did daily exercise for 2 weeks each month. The first group did an arm and leg ergometer. I'll have a picture of that, but that's a machine that you move like this or with the arms, and then an exercise bicycle. And then they did 3 repetition arm and exercise muscles if the muscle had a score on a rating scale that we use of greater than 3, which means that it can be contracted against the weight of the limb from gravity without a weight. And then a group that did just the exercise, and then a group that did passive range of motion. And this control group, in this case, did 2 days a week rather than daily passive exercise. So group number 1 that did the arm and leg ergometry, like the circular motion of the arms and legs, had significantly higher ALS FRS-R, which includes respiratory scores, at the end of the 6-month period. And interestingly, 6 months after the training done, they still had a higher score. And you can see that in this graph here. This is the ALS FRS score on the left, and this is the time out. And this red here represents the difference between the group that did exercise and the group did not. And here's at 6 months. The ALS FRS scores have gone down, but there's still a considerable difference. And this difference was about 5, which is pretty good and is the equivalent or possibly a little better than Radicava, for example, which is effective as well. So it's not a minimal difference. This is the most recent published trial in 2018 from Clausen. This is the Mass General group on safety and tolerability of exercise in ALS. And importantly, this trial was studying whether exercise worsened ALS or whether there was no difference. It wasn't powered. They didn't have enough patients for efficacy. And they had 3 groups that did stretching or range of motion, resistance exercise, or endurance exercise, and they exercised for 6 months. And what they found is that all 3 groups were safe, as no difference in the rates of disease progression. Okay, so they're not over-exercising, and there's a trend towards fewer falls in resistance and exercise groups. This is the most recent paper. It's just a pilot study, but from just a couple of months ago, and that was recumbent stepping exercise in ALS, and that's using a machine like this. You can find them in most gyms, and that's ergometry, kind of like an elliptical of the feet with an elliptical of the hand. What was that guy, the Tony something that did that thing, the Gazelle or something? Do you remember that TV thing? A little bit like that. But this also found that this was safe and did not worsen patients. It's not powered to show an improvement. And I'll send this PowerPoint to Cassie so she could distribute it. We don't really have time to get into the details here, but this is the exercise protocol used in the Mass General study, and you can see they'll say like the number of reps done in 1 RM, that means 1 repetition maximum. So you see what the muscle can lift, and then you only do 40% or 50% or 70%. The important thing is that you're not over-exercising the muscle. And then this is their endurance exercise protocol. They did 10 minutes of upper limb exercise, followed by 10 minutes of lower limb exercise. And so we'll move on now to musculoskeletal pain in ALS, and I wanted to do a little practical teaching here, so that's why I have the handouts for you. What's most important? So a real interesting paper from the group at Leahy Clinic in Boston, Darlene Ho, in 2011, looked at shoulder pain and ALS, a survey, and 45%, nearly half of patients with ALS have experienced shoulder or neck pain. And in 2/3 of the shoulder pain patients, there was an unknown cause. In about 1 out of 5, they had a condition called adhesive capsulitis, where the shoulder capsule becomes inflamed and it's quite uncomfortable with motion. And then about 15% had rotator cuff tendinitis, where the main tendon of the rotator cuff. This is a really common condition. I'm sure there are multiple people in the audience here who have had rotator cuff tendinitis. What they found, though, that this is often undertreated. Only about 50% of the patients with ALS who had this had received treatment. And the really important things to try and prevent this and treat it are range of motion exercises, and then if those aren't successful, steroid injections can be helpful. This is just some shoulder anatomy, the way the bone, this is the upper arm coming into the scapula here, and this is with the muscles, and it's just a really complicated joint. It's the most complicated joint in the body, so when you get decreased muscle force in the muscles of the shoulder from the effect of ALS, you get an unbalance of that, and you can develop shoulder pain from that. So this publication from 2018 from the MGH group. This is with Sabrina Paganoni, who was a fellow with me with Shafiq. Boy, that was a great fellow class. They've both gone on to do great things working with patients with ALS. So this paper looked at exploring the use of educational material about shoulder dysfunction in ALS. And they gave this brochure to inform patients about what exercises to do for shoulder pain. And to start, this is the handout that you have on your table. And it has, so to start, these exercises are active when the patient can contract the muscle to make the movement. And the exercises, there are 3 exercises that are done 3 times each, and then hold on the edge of the range of motion for about 30 seconds and do those once or twice a day. And then once ALS has become significant enough that the muscle can't contract to go through that range of motion on its own, then these can be done with the assistance of a caregiver to do passive range of motion. And I would say the one thing about this paper is that they didn't put those pictures in the paper. So I'm going to have Shafiq come up here, and I'll show you. But it's three ranges. The shoulder is such a real complicated joint because it can go through so many ranges of motion. So the first exercise that you do is shoulder flexion. You put your hand on and hold up like this until it won't go anymore. There's discomfort, and hold that for 30 seconds. You could have some mild discomfort. You don't want to get it to the point where it's super uncomfortable, okay? And back down. And do that 3 times, okay? And then the next exercise is to come out to the side and come out to the point where it's tight and causing some mild discomfort, and hold it there for 30 seconds. Okay. And back down, and then you repeat that 2 more times. And then the third time is to hold the elbow at the side and come out this way until it stops. Or you want to have the beginning of a little bit of discomfort, but not to where it hurts, and hold it for 30 seconds, and then come in like this. And you've got that on that handout that's been placed on your tables. It just shows the patient doing it themselves, and I think it's important to cover that these are just as effective, if not more effective, if someone's assisting with them. Thanks, Shafiq. Yep. So these are the exercises that you got there on the handout. So putting into practice, so getting started with exercise. Remember, one size doesn't fit all, and of course, some of these exercises as ALS advances are not possible, but we wanted to just cover that concentric exercises are good, eccentric exercises are not good. That possible exercise muscles with this muscle score MRC 4 or 5 or greater, that means that the muscle has some weakness but is greater than anti-gravity. And if you have questions about that, you can check with your neurologist because they're putting it in their exam notes, or your physical therapist, and why these muscles will respond to exercise. Once they get to just anti-gravity, they're probably getting enough exercise just from activities of daily living. And then focusing on these responsive muscles may enhance the overall function of limbs. I want to just make a point to avoid personal trainers. I have nothing against them. I've never had one myself, but I get one from my dad, who calls me a helicopter child. But the thing about personal trainers is that they're trained as a whole, as a group, they're trained on methods for normal muscle, and that the training doesn't include education about treating muscles with structural change or decreased nerve supply. And personal trainers tend to focus on eccentric exercises because they're very effective in normal muscle. And so they tend to push patients to full muscle fatigue. And so I have had patients with ALS who got personal trainers early in the stage of the disease, and it ended up being detrimental. Here's a curriculum for the Lake Washington Institute of Technology in Kirkland for a fitness specialist or personal trainer. And you can see here, they're learning a ton. And they're learning a ton about kinesiology, but none of this is about disease. Okay, so I would ask you to be so when you're doing aerobic exercise, you shouldn't do it to the point where you can't hold a comfortable conversation. That doesn't mean you have to talk the whole time. And I did make the mistake one time at Boston in telling a patient, you need to be able to talk the whole time, and she came back for a 6-month follow-up and said, it's going great. The exercise has gone well, but my family is sick of having to talk to me the whole time. I'm like, I need to explain myself better. So a real simple thing that you can do, the same thing they do in an exercise lab, is the talk test, where you're able to just speak comfortably during the exercise. You're exerting yourself, but you're not getting short enough of breath that you couldn't maintain a conversation. And there's good research that gets you to right where most of the exercise studies that are done in nerve and muscle disease are at. It's about 65% of VO2 max. And so we want you to think about doing stretching or range of motion exercises. They're really helpful for patients who have ALS to prevent contractures, reduce pain and spasticity. That gentle aerobic exercises, when possible, to maintain cardiovascular fitness can be performed, as long as they're safe without a risk of falling or injury, and then you do it at a level that you can talk while exercising, and that moderate resistance strength training in earlier or mild ALS has shown to be helpful, and just don't overdo it. These are some, in early ALS, a weight that can be lifted 20 times, do it about 8 to 10 times of that weight, so you're never going to full exhaustion of the muscle. And then later on in ALS, you can do a little more than half of what can be lifted one time, 3 sets of 3 reps. And again, to avoid personal trainers and communicate with physical therapists. It is the ALS Association of Southwestern Washington, so I put some Seahawk thing in there. So to make it real simple, no exercise is bad, moderate exercise is good, and extreme exercise is bad. And then, you know, it really, in working with patients and giving them the go-ahead to exercise, I think it's really helpful for quality of life too, and the locus of control. You know, an external locus of control, something happens to you, you can't really fight it. An internal locus of control, you can participate in the fight against the disease. And just a specific patient, a 65-year-old with ALS who I saw in Boston, a Vietnam vet, and he was self-referred in for a second opinion, and he'd been seen in Boston, a great ALS Association clinic. I may have quoted a paper from them today, but I won't say, but he was told by a physical therapist there, don't do any exercise, you're just going to make yourself weaker. And that was really discouraging to the patient, and really added to the marked depression. It's just hard to sit here and take it. So, you know, he had quite a bit of widespread decreased muscle force or weakness, but we counseled him about doing pool exercises and not overdoing it, because a lot of people who have ALS were really intense athletes. And so you have to tell them, you know, don't push 100%. And at 3-month follow-up, he actually had gotten some increase in strength, and he just felt a lot better. I think his exact quote was, "I'm going to give some fight to this bastard." At 6 months, the strength was no longer improved, but comparable to the initial assessment. At 9 months, the exam had worsened, but the affect was still better. You know, like how he felt was still better. So thanks. I hope I got done in time, and I just want to give special thanks to a couple of people who have done a lot of work in ALS and exercise. Thanks.